So this patient was kept in the ICU. Unfortunately, post-op day 3, the patient started having increased work of breathing and loss of function in the deltoids and biceps. So the patient's neurological exam was the same for post-op day 0, day 1, and day 2. In the morning of day 3, even after he was extubated, his work of breathing was getting worse, and he lost function in his deltoids and biceps. So there has been a neurological change that needs to be assessed. You always think of a couple of things. You would want to make sure that the patient does not have an epidural hematoma after the decompression that's causing worsening neurological deficit, or spinal cord swelling. And how do you make an assessment on that? Is by getting an MRI. And you can see here there was no blood clot or compression on the spine. Intrinsically, the spine was swelling, and with this ascending edema, the patient lost his neurological exam. He had to be re-intubated for increased work of breathing. Obviously, the breathing center here is at bottom of the brainstem, C1 and C2. So he was intubated emergently, and also was placed on some steroids to try to decrease the swelling, and his exam improved. Ultimately, the patient was discharged to an LTAC and then to a rehab. He improved neurologically, but he remained non-ambulatory. He regained some strength in his hand intrinsics. So this is the case that we just discussed, a case on fracture dislocation. Does anyone have any questions? I was hoping for an interactive session. So if you have any questions, please unmute your microphones and go ahead and ask.
Dr. Dahdaleh, I have a question.
Sure thing.
Is there like a similar like ranking scale to categorize instability for the lumbar spine, as comprehensive as was mentioned here for cervical?
Excellent question. It's absolutely yes. It's the TLIC score, the thoracolumbar injury classification system, put forth by the same trauma study group led by Alexander Vaccaro. It's robustly used, and these two classification systems are useful because they're not only descriptive, they also guide management. And the basics of the TLIC system is similar to the cervical spine, subaxial cervical spine injury system or scale. It looks at three things, three categories: neurological exam, the morphology of the fracture, whether it's a compression fracture, burst fracture, fracture dislocation, flexion distraction injury, perched facets, unilateral, bilateral. And the third thing it looks at is the integrity of the posterior ligamentous complex. To complete the picture and to make an accurate assessment, you got to assess those ligaments. So similar to the subaxial injury classification system, the TLIC looks at the same components in order to come up with an injury score that would guide you in terms of treatment. Now, in the world of thoracolumbar injury, compression fractures, usually the ligaments are intact and the patients are intact neurologically. So all of them, most, if not all of them, are managed with bracing. The other extreme is a fracture dislocation. Most patients have a deficit, and definitely the ligaments are injured. So for patients with a flexion distraction injury or a fracture dislocation involving all three columns, they're managed surgically. The debate in terms of is with managing patients with burst fractures of the anterior and middle columns. That's where the debate is. And that's where you need to look at these other criteria closely. So when you want to manage a burst fracture, what's going to break the deal is whether or not the ligaments are disrupted and whether or not the patient has a deficit. If a patient has a deficit, by definition, this burst fracture is unstable and you need to manage it with surgery. Or if the patient has disruption of the posterior ligaments, that would put the patient in the category of instability, needing surgical stabilization. Now, the technique going anteriorly with a corpectomy or posterior with long or short segment fusion or both, it's a different discussion. But at this stage, identifying whether or not a patient has an unstable injury is very important for the sake of this lecture and cases. Any other questions?
Yeah, Nader. So, oh, sorry. Does somebody else have a question? You called on me before, and I couldn't get to my microphone in time. But I want to. If somebody else had a question, I don't want to step in. If somebody else is.
Yeah, I have another question. So I'm looking at the subaxial injury classification scale again, and then it says that complete cord injury gets 2 points, but incomplete cord injury gets 3 points. And I was just wondering why an incomplete cord injury would get more points than a complete cord injury if it's like less severe.
Excellent question, Mariam. Actually, this is an excellent question. It's just to show you that a patient with an incomplete injury, we're worried about that patient more. I mean, more than the patient with a complete injury, because this patient with an incomplete injury may be salvageable. You know, if you have a better neurological exam, the chances of you getting better with an operation is huge. So that's why they reflected that in the system, whereby they give that patient a higher score, just to show that, you know, the patient has a deficit. Definitely, any patient with a deficit is has inherently an unstable spinal injury. But in terms of urgency, that patient got to pay attention to the most, because patient has not gone to become a complete ASIA injury patient. So there's a lot of room for that patient to regain a lot of function. So that's why you got to intervene, and you want to pay attention to that patient a lot. It's not that we don't pay attention to patients with ASIA injuries. Actually, patients with a complete spinal cord injury benefit the most with what we call ultra early surgery too. But an incomplete injury, you know, you worry about them. It's like, wow, this patient has a let's say 3 out of 5 exam. I don't want it to become 0, because the spine is unstable. It's so biomechanically unstable that any movement would cause more compression and a worse deficit. So let's act fast and salvage that patient.
Okay,
with an
thank you.
operation. Yeah.
I had one more question, actually. Is there a role for like spinal sagittal balance parameters in the handling of like devising the treatment plan for in the setting of trauma, or is that primarily just for like degenerative spine conditions?
Excellent question. It's you know, you always want to keep it in your mind, or in the back of your mind, to put the patient in the best sagittal alignment possible when you're stabilizing them. Meaning that, let's say a patient has well, I mean, this patient with fracture dislocation, obviously he's forward because of the dislocation. When you reduce it, you can restore sagittal alignment. But for instance, you don't want to fuse those patients flat. You want to make sure that if you want to go anteriorly, put a lordotic cage, you want to maintain their lordosis as much as you can when you're stabilizing them. It's not the primary driver in terms of decision making. Let's say you have a patient with positive SVA, sagittal vertical axis, who has an unstable spinal fracture. You're paying more attention to stabilizing the fracture than to making the patient sagittally perfect, because you want to focus on the pathology. Because let's say this patient's sagittal malalignment is caused by upper thoracic kyphosis, okay, and the fracture is in the middle of the cervical spine. You're not going to fix the upper thoracic kyphosis. You want to fix the fracture, and then go from there, because the patient's primary chief complaint is the deficit due to the fracture, and not necessarily his baseline vertical positive SVA or sagittal vertical axis. You want to keep it in mind when you're fixing them. You don't want to fix them flat, but that's not the main driver in terms of decision making. Important thing is to identify the unstable fracture, and then give the patient the best construct that would maintain biomechanical integrity to the spine.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.